All right, good morning, good afternoon, everybody. Welcome to another session of Clinical Problem Solvers VMR. We have a slightly different VMR today. It'll be me, Ravi, and I was able to rope in my good friend, Kirtan Patolia, who's going to help me today in discussing a case. And so I'm very happy to see a lot of familiar faces and a lot of repeat visitors to VMR. And I'm really excited to see if anyone can present a case and possibly test both me and Kirtan and hopefully learn from this case. So before we get started, if anybody has a case, please either unmute yourself and let us know or type in the chat. Oh, Franco is here too, I see. Okay. Hey, Franco. So Franco will also be helping us. So it'll be a tag team, three of us, sort of sharing thoughts, and we've done sessions together. We've done sessions outside of VMR, and I thought it'd be a great session or repeat session to before they start internship, to have them come on and relive the old times. So I'm gonna let Franco and then Kirtan introduce themselves. You want to start, Franco?
Hi, sure. I'm Franco. I'm from Peru. And this is the first time I am here at the VMR at Baltimore, because I just recently moved. I'm going to start as a PGY1 in internal medicine at Sinai Hospital. So I will pass the mic to Kirtan.
Hello, friends. Good morning. I am so excited to join the old team of Dr. Singh and Franco today, because we have been together on many CP Solvers bootcamp episodes. So it is very nice to join them back. And I am also excited for another reason, that in the chat and in the participants list, I'm seeing so many new faces. So, inspired by our team member, Dr. Jack, who often does this, that whenever we have many new faces, we kindly introduce, and we give them opportunity to introduce themselves if they are joining for the first or second time, and kind of ask themselves a bit about where they are joining us from, how they came to know about us, what are their interests outside medicine. So if anyone is joining us for the first or second time, that please drop a hi in the chat. And thank you so much for joining us. Hey Pallavi, so nice of you to say hi in the chat. And if you are in a place where you can unmute yourself, then we would love to hear from you.
Hi, Kirtan. Thank you so much. I unfortunately cannot turn on my video. Apologize about that. I heard about CP Solvers first through Twitter and had been following a few updates. I did realize that I saw a few clinical reasoning related schemas and then grew curious. And I think this is my second or third time here today. I trained as a doctor in India, and for close to 7-8 years now, I have been living in the US. I have worked as a clinical researcher in different academic institutions, including Thomas Jefferson and Brigham and Women's. I hope to apply for residency again later this March. So prepping for that, and I kind of feel that CP Solvers is a great primer for, kind of re-entry into that field of clinical reasoning after you've been engaged in research for a while. So I'm very grateful to be here.
Thank you. Thank you so much for joining us, Dr. Pallavi. And, we are grateful that we have an expert on our chat list today. So I'm sure that it will help us navigating the case.
We also have, I just want to do a shout out to Christian, who is currently in a busy place, so he can't unmute his mic, but he's also a recent visitor. So I just want to recognize him as well for joining with CPS today. So we'll keep waiting. If anybody has a case that they could present, it could be a case that you may have recently encountered, even unfinished cases. Maybe we can help you get close to a diagnosis. I see my friend here, Jane. How are you, Jane?
I'm good. I'm just continuing to study for step 2, taking it next week. So,
Good
yeah,
luck.
thank you.
Yeah, I see you quite a bit here on VMR. So I'm always like, oh, Jane's here today. It's always good to see you, and very encouraged by your enthusiasm and continued learning.
Yeah, I love it here. It's really great to see everyone and always enjoy the discussions.
Oh, Franco has a case. Franco.
Yes, if there is no case available, I can present, no problem.
Sure. I think, yeah, let's definitely discuss your case. So we'll have to scribe. I don't think we have anybody for scribing, but Gideon, can you start the
Yes.
whiteboard? And
Sure.
Franco, give us the first piece or the first aliquot of the case.
Perfect. So the chief complaint would be 32-year-old male with itching in both eyes with redness and itching in both eyes for a week. Do you want me to stop there, or should I give you a little more of the HPI?
Yeah, let's stop there. So Kirtan, you want to start with the first aliquot there?
So thank you so much to Franco for presenting a case to us. So when we are dealing with something like itching in both eyes along with the redness, then we should always keep in mind the base rate of the disease and how we can link that to our case. So whenever we think of itching, the most common thing that we have to be aware of is maybe this is something related to allergy, right? So getting a history is very important, making sure that patient has not suffered from such complaints in the past or maybe suffering for the first time. So that will guide us further. Apart from that, the redness part. So now could it be inflammation? Could it be infection? And maybe the patient has suffered a recent trauma. Maybe the patient had, some kind of foreign object lurking in his eyes. So we need to ask a history before we move ahead. And once we have ruled out the common conditions, we can start looking at the anatomy, right? Could it be conjunctivitis? Could it be scleritis? Could it be uveitis? Could it be something coming from periocular structures like soft tissues, nasal cavities, sinuses? So having an anatomical approach once we have a problem at hand is important. And once we get the more data, we can apply the physiology part, that what kind of disease processes can cause itching and redness. So those are my thoughts. Now, what do you think, Dr. Singh? How we can proceed?
I don't think I have much to add to this. My question would be, is this the main complaint? Is this what we should be following, or is this a sign of a systemic disease? So is this a primary process? Is the eye involved? And like you nicely outlined, could there be an infection? Could there be inflammation? There's a plethora of eye-related issues that can cause the red eye. Then we have to start with what could be very dangerous, because with the eye, you definitely don't want to miss something that could cause loss of vision. So at this juncture, I think we sort of have a 10,000-foot view, and we're looking at the major categories, like you mentioned. Was there trauma? Is there inflammation? Is there infection? Is the infection viral, bacterial, fungal, and so on? And then are there any risk factors that the patient may have for other atypical organisms if there is an infection at hand? So we definitely will obtain more information from Franco's next aliquot.
Great, I really love how is going. So for the HPI, I will combine it a little bit with the previous medical history. So this patient has ankylosing spondylitis on TNF inhibitors for 3 years, diabetes, currently using long-acting insulin, has had two previous episodes of episcleritis, and also has an unspecified inflammatory bowel disease. This patient presented for a whole week with redness and itching of both eyes that initially didn't make much problem with the vision, but on the previous day that he went to the emergency department, he saw some floaters around the left eye. He said that it was approximately a quarter of the right eye field vision, and the right eye still has some itches and redness, but no flutters in there. Regarding the family history, non-contributory, social history, no. Health-related behaviors, no. Allergies, no. And I think I can stop there.
So, Ketan, you can take the first dib at this laboratory history.
And before I move ahead, I just wanted to encourage everyone in the chat to share their thoughts. We would love to highlight you and we would love to learn from your wisdom as well. So please don't hesitate to share your thoughts in the chat. And now we have very interesting data coming from the past medical history. And we always learn that how history is integral part. So as we discussed in the first aliquot, that history will pave our path forward, and that is turning true actually. So the patient has past medical history of ankylosing spondylitis. Patient has been on numerous medications and unspecified inflammatory bowel disease. So how can we link these findings? So talking about anatomy, if you think about the redness of the eyes, then classically it stems from the conjunctivitis, or it can also be from the scleritis or episcleritis. But generally in the scleritis, you tend to get a deep purplish kind of hue rather than just a superficial redness. So, again, going to the bedside of the patient and examining the conjunctiva nicely and getting an ophthalmology involved would be very helpful to delineate among these etiologies. And also uveitis. So in uveitis, classically you see the circumoral kind of injection, circumlimbal kind of injections, and uveitis can also present with the redness. And the reason why I am alluding to uveitis is because ankylosing spondylitis and other HLA-B27 related disorders, including inflammatory bowel disease, reactive arthritis, and psoriatic arthritis have tendency to involve the uvea, and it can lead to uveitis. And the floaters is also very important because if you think about it, usually in conjunctivitis, if it is isolated, or in scleritis or episcleritis, you won't consider the floaters because that is not how it presents. But if you have the uveitis, then you can get floaters because the vitreous fluid can be inflamed. And if you have the vitritis, then you can get the floaters. So anatomically speaking, we are focusing on the uveitis. And systemically speaking, then AS and other disorders can present with uveitis, so that is important. And now coming to the medications part, we know that the patient is on TNF-alpha inhibitors, so it increases the risk of numerous infections, including various granulomatous, fungal infections, granulomatous, bacterial infections, mycobacterial infections. So as Dr. Singh alluded to us in the first report, that we shouldn't lose the sight of life-threatening disorders, which can immediately threaten the vision. So I guess infections, including mycobacterial infections, will be one of them. And then as per the base rate of the disease, lastly, the patient has diabetes. So we know that those patients who have diabetes, and if it is especially uncontrolled, then we have higher tendency to get many fungal infections, which can hit the eyes, like aspergillus is there, mucormycosis is there, and even run-of-the-mill sinusitis and conjunctivitis can happen in patients with diabetes. So keeping all these things in mind, we can move ahead. And Dr. Singh, do we have some interesting things coming in the chat? Then we can highlight them.
Yeah, I'm seeing a couple of thoughts that Nikita mentions. The IBD could be ulcerative colitis, seronegative spondyloarthropathies, HLA-B27 Jad mentions. So definitely where our thoughts are along the train of IBD associated, I guess, systemic disease, so in this case, ankylosing spondylitis. I just know that acute anterior uveitis is usually associated with this, but I doubt Franco is going to give us a systemic disease with the usual associated eye disorder. But maybe there's something else brewing under the surface, just like you mentioned. And I initially mentioned, could there be a superimposed infection? Again, the categories are quite broad. And like you mentioned, the TNF inhibitors can definitely set up this patient for a very serious infection of the eye. The floaters, again, usually we're taught that floaters are not detrimental to the eye, but I guess the quantity can be significant where it can impair vision, but it is usual to see floaters. But I guess I don't know too much about this, but definitely something to look up if the number of floaters are increasing, or if there's other precipitants in the chamber of the eye causing those floater-like visual opacifications, I guess. Franco, any more elaboration on the history, or do you want to go into the physical?
So just to clarify that the patient never reported any fever or headache. I see in the chat that there was a question about what meds is the patient on. The TNF inhibitor that he used is Symphony. The long anti-insulin, I don't quite have that here. So I can go on with the vitals. All the vitals, temperature, heart rate, blood pressure, and respiratory rate were within normal limits. In the general exam, he looked non-critical, non-ill, but kind of disturbed because of the decrease of the vision in the left eye. HENT only noticed the redness on both eyes, and per the examination of the ophthalmoscopy, he saw that there wasn't only floaters in the left eye, but also some kind of imaging that looked bigger than a floater. I will not disclose the exact name that he saw in that time because that would kind of reveal the whole diagnosis, but there was big floaters around the eye. The rest of the examination was normal.
Okay, I guess while Kirtan's typing in on the whiteboard, I'll start. So vital signs, so no fever, no signal of in systemic infection, although infection could localize to the eye. But what's really significant here, the patient has redness in both eyes. Endoscope or fundoscopy shows floaters, a typical floater like big objects. And what we typically understand about floaters are they're usually smaller. So this is probably not your garden variety floater, but must be another sort of precipitant in the chamber of the eye. So I'm kind of wondering what kind of pathology could manifest in the humor of the eye that could be large and could also impair vision and also manifest with inflammation of the sclera. So you have possibly anterior uveitis, conjunctivitis, keratitis, any number of those inflammation of the structures with also involving the humor of the eye as well. Kirtan, anything to add?
Yes, thank you for passing the mic, Dr. Singh. And before I share my thoughts, I just wanted to ask Dr. Pallavi again to share her thoughts if she is in position to unmute herself, because she has some interesting ideas about how to evaluate these floaters and floater-like objects. So Dr. Pallavi, if you are in a place, please share your thoughts.
Yeah, hi. I do know that a sudden increase in floaters, like at a detailed eye exam, of course, here as internists, we only have access to, the ophthalmoscope. But a dilated slit lamp examination can, if done for floaters, can sometimes reveal something called lattice degeneration. So the retinal arrangement is like in a matrix pattern with interlinkings, and that starts to separate out, which is manifested as, increase in floaters. I am not sure if it's, if it's okay to consider if in case of floaters increasing in only one eye. I have always assumed that happened bilaterally. But I do know that it's considered to be a precursor to premature retinal detachment, and that it is treated with urgency with laser coagulation. So that's like immediately as I heard of, an increase in floaters, that's where my mind went, despite all the other accompanying inflammatory bowel disease and ankylosing spondylitis. That's just because I've seen those cases. So that's why I sent that thought out.
Thank you. Thank you so much for painting a very comprehensive picture for us. It was very enlightening to hear about the classification of floaters and how to think about them. And one thought that jumped out to me was that Franco is highlighting one point again and again, that always there is some sort of unilaterality. Like often in inflammatory disorders, you assume that their things would be bilateral. And even in our case, it could still be related to inflammation, because we know that in autoimmune disorders, sometimes one eye is involved currently, but maybe after a week or two, another eye will be involved and things will be bilateral. We are just ahead of time. That's one of the reasons. But if we consider that things are actually asymmetric, then how we can incorporate the TNF alpha inhibitors part? So as we alluded to the infections earlier, sometimes, parasitic infections, they have larvae, right? And those larvae can migrate through the eyes and other structures, and maybe those larvae are manifesting like big objects. So we know that visceral larva migrants can have component which is known as the ocular larva migrants, which can manifest like this. And we know that toxocariasis, toxoplasmosis also have predilection to hit the retina and can cause neuroretinitis. And talking about the bacteria, sometimes Bartonella, along with the Mycobacterium tuberculosis, can cause retinitis, and maybe they can present as giant floaters as well. So keeping at the back of mind all the parasites, including strongyloids, Toxocara, Toxoplasma, and that's why CBC will be very critical to see if there is evidence of eosinophilia, although it may not be present all the time, but still we can look out for them. So as of now, infections are high on differential, apart from the autoinflammatory disorders that we have already mentioned. So Dr. Singh, do you have any thoughts to add before we can move ahead?
Oh, you actually covered quite a bit there. Yeah, it's interesting what to connect here again. Is this a primary process, or is this secondary to, you have this autoimmune disorder, then you have this TNF alpha inhibitor, and you touched upon that. Can that be the cause, or should we follow that lead to see if there's a complication of that? And again, getting back to infections, the one infection that definitely stands out is TB. And TB, I'm not sure where this patient is from, but TB within the eye, especially massive floaters, that to me is not your, again, the garden variety floaters that you may have, but you're probably manifesting with having some extraocular manifestation of disease that is then precipitating within the eye, within the humor of the eye. So again, TB comes, actually is high on my differential, but then comes other diseases such as fungal disorders due to this immunocompromised status. So again, like, are we dealing with an immunocompetent or immunocompromised patient? I would say immunocompromised patient. Then we have to go down the line of immunocompromised or infections that usually target immunocompromised patients. And again, the list is vast. You can go through viral, bacterial, and also fungal, and parasites was a very good thought. And I always see those videos online where you see worms coming out of eyes and things like that. Very it grossed me out quite a bit. But one that comes to mind is a lower that, where you get the worm floating across or causing a visual impairment across the eye. Any other thoughts, Kirtan?
No, I think we are good to go. Franco, please share us the next report.
Perfect. I really love how it is going. To answer some questions, the patient is from Peru. He hasn't had any symptomatic tuberculosis, but he had 4 years ago a positive quantinterferon that was treated with 6 months of prophylaxis due to latent tuberculosis. But after that, no, he hasn't had any problem with that. So for the labs, I only have the hemogram. So that's the only thing that you're gonna get, because after this, I will reveal the diagnosis. So the hemoglobin is in 13.7, the hematocrit 41.9, the leukocyte count is in 12,800. The eosinophils are in 1,000. The neutrophils are within normal limits. The platelets are in 400,000, yeah. And Oh, I have a PCR also. The PCR is elevated in 25. And that's everything I have for you until now.
I'm sorry, Franco, can you repeat the last labs? What was elevated?
Oh, the CPR. The CRP
Oh,
is elevated in
CRP,
20.
right.
Sorry, I had a,
It's
had
all
a
right.
problem in translating speaking Spanish and English. Sorry. The CRP is high in 20.
All right, Ketan, you want to take a stab at this one, the labs?
As we were thinking about possible parasitic infections, which can manifest as floaters and which can cause such redness and inflammation in the eye. And that's why we were hoping that maybe we will find some evidence in the lab findings. And we now do have the evidence of eosinophilia. And, I just wanted to share one brief pearl, which I learned from our podcast itself, that whenever you see the CBC and when you see the differential in the form of percentage of eosinophils, you should not, it is not a reliable marker of eosinophilia because you should always look for absolute eosinophil count. So in our case, I am happy that Franco has given us the absolute eosinophil count itself so that we don't have to calculate that what is the eosinophil count. And there are various definitions, but usually when we have absolute eosinophil count exceeding the 500, then we can consider it as eosinophilia. And now, what are the infections which can cause eosinophilia? So, I just wanted to highlight the Febrile podcast. It has been an amazing podcast. And I personally love that podcast, learn a lot from that. So in that podcast, there was one specific episode regarding the parasites and the eosinophilia, what can cause eosinophilia. So talking about the parasites, we classify them as trematodes, then there are roundworms, then there are helminths. So the big names are schistosomiasis, strongyloids, toxocara, toxoplasma, and as Dr. Singh mentioned, onchocerca and loa loa. And if I'm not wrong, both of them can be found in South America, where this patient is residing. So definitely something worth considering, apart from the other visceral larva migrants part. And apart from parasites, tuberculosis, Lyme disease, syphilis, and even the fungal infections like coccidiomycosis classically can lead to eosinophilia. So we should think about them. And rarely there are some malignancies like lymphoma, we can also contribute to eosinophilia. So in our case, I am anchoring on the parasites because of the social history, because of the way the disease is presenting in asymmetric fashion and relative acuity of the disease. But I'm sure that Franco can surprise us at any time with his teaching. So excited to see how this goes. And meanwhile, Dr. Singh, do you have any thoughts before we move ahead?
Oh, no, I definitely putting parasites and definitely I'm having some hesitancy thinking about parasites, worms in the eye. And you nicely compiled a list of parasitic infections of the eye that we could be dealing with. But yes, we also should not just stay within the domain of parasites. Could this be an eosinophilic manifestation within the eye? So could there be a systemic eosinophilic syndrome? Less likely, we're not getting that picture from Franco's physical exam and patients' complaints as well. What we could also entertain, I definitely would like to get a HIV test on the patient too, and then also go down the route of HIV-associated infections. And leptospirosis definitely is interesting when you have redness of the eyes bilaterally. So that's something to think about. And then patient doesn't wear contacts, right? I guess we always get tested on board exams for acanthamoeba, which can happen with contact lens wearers as well. And then other ones, toxoplasmosis, you mentioned. I think also again, sort of fungal infections can potentially cause eosinophilia too. So going the route of aspergillosis and so on. And what's another one? I think malaria could also manifest in this way too, but I'm not sure. I don't think eosinophilia would be found in the labs in such a high number as well. But those are a few thoughts here. Definitely difficult when it comes to the eyes. Not something we definitely deal with within the hospital. One thing I like to throw out there though is in acute retroviral syndrome, you can get bilateral conjunctivitis. something that we can see. So in the acute phase of HIV, but you would have associated fevers, chills, lymphadenopathy, lack of appetite, and other constitutional symptoms as well. But we're not getting that sort of flavor from this patient. We're getting just the eyes, and visual disturbance are definitely the priority here. Anything else, Ketan, comes to mind?
No, I think I just wanted to, highlight that how you brilliantly mentioned the HIV part. That is something that always keeps our mind. And I always, try to ensure that I don't forget the HIV, because no matter how the epidemiology, how the presentation, but we should not miss the HIV. So thank you for highlighting that and reminding us that HIV should be on differential and we should obtain that test regardless of anything else. So now, Franco, do you have anything to share? And maybe, I would also love to see that how you solve this case in real time, like what were going through your mind and your team's thinking. That would enlighten us as well.
Right. So at this point, we were almost in the same track than you. So we took a more detailed history with the patient. We reviewed his past medical history and all the clinical records that we have. So apparently the eosinophil count has been going up and down intermittently. And that the only times that the eosinophil count is going to decrease is when the patient takes his TNF inhibitor. So every month he used the golimumab, and at the end of the month before the next dose, the eosinophils rise up. There was also a high degree of astigmatism in this patient since childhood. And after consulting with a retinal specialist, he concluded that the strange floaters on the left eye was effectively a retinal detachment, and he was scheduled for surgery on that eye. And the right eye has some degree of minimal retinal detachments. And the conclusion was that this patient probably has an uncontrolled polysyndromic or polyphacetic picture of the ankylosing spondylitis, and the recurrent episodes of the episcleritis, untreated or bad treated, cause the inflammation, the attachment of the retina. So the right eye was taken with laser, and the left eye is going to be taken in a more specialized surgery because there is a high degree of retinal detachment. So for me, the important part of this case is not to lose focus on what someone previously mentioned. Sorry if I forgot the name, that if there is vision loss, the emergency that needs to be ruled out first is retinal detachment. And that's treatment before diagnosing. And this is probably the case of this patient having a lot of autoimmune disease process there. And their taking point is that eosinophils are sometimes elevated in autoimmune diseases, especially the ones that involve the GI tract. So there's not only anchor with high eosinophil counts with parasites, because that can also happen in autoimmune diseases.
Dr. Singh, do you want to share your thoughts?
Go ahead. I'm going to just fill in the teaching points.
Sure. So thank you so much, Franco. What an amazing case. And I just wanted to highlight the voice of Dr. Pallavi, she was the first one who mentioned that how retinal detachment can manifest as floaters. And even though in autoimmune disorders like ankylosing spondylitis, we may not classically associate the retinitis with it, but the fact that there is uveitis and you can get posterior uveitis, and we know that when you get posterior uveitis, there is always a chance that inflammation will spill in the retina part, and you will get retinitis and inflammatory cells in the vitreous itself, which can manifest as floaters. So that was a very nice reminder, Franco. And I also love the eosinophilia part. We know that there are some autoimmune disorders like, sarcoidosis, sometimes even lupus, and now this inflammatory bowel disease can also present with eosinophilia. So even though the findings are unilateral, we should still keep the autoinflammatory and autoimmune disorders at the back of our mind. And so that was an amazing case for me. I learned a lot. Thank you, Franco.
Yeah, definitely. I just like to add in reflection. As we're going through this journey of this case, there's many diversions that are along the route, and definitely you can see the eosinophilia. We can definitely go down that rabbit hole, but it can be explained by this primary autoimmune process that the patient has. So you got to be really careful and then retract back from that path and stay on the path. And just like what was mentioned in the chat, that retinal detachment can be a very obvious cause of something like this. So what's the base rate of disease? What's the most common thing that you will see? You have to keep in mind that retinal detachment can be a cause, and definitely, like Ethan mentioned, it can be an emergency cause. So you have to go through some sort of algorithm. Does this pain? So this patient has red eye. Does this patient have pain, blurring of vision, photophobia, discharge? At that point, you need to get an ophthalmology referral emergently. So in the emergency room, a case like this would go straight to ophthalmology. So bypassing us, but I definitely have a lot of gaps in knowledge with such a case, but I learned a lot. I really appreciate you, Franco, because every time you come to VMR, you learn something. Like, I didn't know this, and then you're motivated to go and spend some time learning it. But a fantastic case. I really appreciate the input from the crowd. It was wonderful. Should we just go through some teaching points? I try to capture as many teaching points, but it was difficult to do both the scribe and the teaching points. So if you want to fill in anything, Ethan, but I just have a couple of points. So we started out with initially mentioning that what an anatomical approach to the eye. So going through all the different layers, going through the iris, cornea, going through both chambers, anterior, posterior chamber, going to the retina, the heart of the matter there. And then going through what could be causing disorder. Are we dealing with a structural disorder, like the diagnosis here? Are we dealing with uveitis? Are we dealing with episcleritis, conjunctivitis? Are we dealing with eyelid issues here? So you can have different eyelid disorders like an entropion, or you can have a very dangerous condition with orbital disorders called presyncopal and orbital cellulitis. Again, that is a very very dangerous diagnosis, which you need to get ophthalmology involved, the orbital cellulitis, and that would manifest with a frozen eye and extreme pain around the eye as well. And then also entertaining the thoughts of systemic diseases and associated eye conditions, such as what Keaton mentioned, the episcleritis, uveitis, and so on. So with IBD, ankylosing spondylitis, psoriatic arthritis, sarcoidosis, Behçet, Sézary, and ANCA-associated diseases. And then we had TNF inhibitors, which we had to entertain as, like, could this also signal complications, or this patient is immunocompromised due to this condition? So what kind of esoteric infections can the patient be exposed to? So fungal infections, definitely viral infections, and your garden variety bacterial infections. And then with emphasis on TB. And what was interesting, the patient did have a quantiferon that was positive 4 years ago, and also mentioning HIV there. And then this floater business, like, again, we usually commonly see floaters, but a large floater like this should make you aware that there's something else going in the background. So definitely what I learned is retinal detachment can manifest with these large floater-like manifestations on funduscopy. Eosinophilia, could that have led us to the diagnosis? But in the meantime, it was just secondary to the patient's primary process, the autoimmune phenomena that was at play. But eosinophilia could be secondary to parasitic infections, fungal, HIV, autoimmune disorders, or malignancy as well. And when thinking about emergency loss of vision, check retinal detachment, CRAO, CRVO, orbital cellulitis, and acute angle closure glaucoma. And I think that's it. Anything to add? Any other teaching points, Franco? I mean, or Franco and Kirtan, I would say.
Do you have anything to add?
Oh, sorry, go ahead, Kirtan.
I am just referring to you that. Do you have anything to add?
Oh, I think you completely nailed the point with the teaching point, Dr. Rabbit. So it's perfect.
All right. Yeah, good. We try to do the best. Trying to scribe and do teaching points like that it's not easy, but we tried the best. But I really appreciate you bringing this case. It definitely is not our run-of-the-mill shortness of breath or chest pain or something like that. You definitely took us out of our element, which we try to do here. So I really appreciate that case. And thanks, Keaton, for coming on and helping me with this case.
Thank you to crowd for joining us and sharing their thoughts. And thank you to Dr. Singh and Franco for dropping by. It was a pleasure and hope to see you tomorrow, friends. Take care.
Take care, everyone. Bye.